The evidence has changed since the last international working group update on Alzheimer's disease criteria. In 2021, we hold our last update where we considered that asymptomatic individuals who had positive biomarker for the Alzheimer pathology were only at risk. And since then, we have gathered new evidence, especially from a longitudinal cohort in cognitively unimpaired individuals who underwent both amyloid and tau PET. And these data have shown us that we have two subgroups with very different lifetime risk of developing symptoms, which are on the one hand, the amyloid positive and tau negative cognitively unimpaired individuals who have a significantly increased but low risk to develop symptoms. They have approximately 15 to 20% risk of developing symptoms in the following 6 years. And we have, on the other hand, individuals who are amyloid positive and tau positive. And these individuals have a very high risk of developing symptoms in the upcoming years, within 80 to 85%. So we have new evidence for risk in these individuals, and the International Working Group has always defined Alzheimer's disease as a clinical biological disease concept, meaning that either you need symptoms and biomarkers to have Alzheimer's disease, or a very high risk of developing Alzheimer's symptoms together with specific biomarkers of Alzheimer's disease to be called pre-symptomatic Alzheimer's disease. So we have this new evidence of very high risk group. And before 2024, we only defined pre-symptomatic Alzheimer's disease for individuals who had autosomal dominant mutations of Alzheimer's disease. And now we propose expanding this group to individuals who are amyloid positive and tau positive, cognitively unimpaired. So we expand this definition in sporadic Alzheimer's disease for the very high risk group. On the other hand, we keep maintaining the different disease label, which is the asymptomatic at-risk individuals. We do not call them Alzheimer's, and we tell them that they have a higher risk and that this risk needs to be assessed together with other risks, like core pathology, vascular risk factors, etc. And that risk needs to be monitored and needs to lead to specific interventions. But we do not say that it's a continuum. We do not say that they belong to the same biological category as the individuals who have high risk or who have symptoms, because a large majority of them don't have symptoms and will never develop symptoms in their lifetime. So we think it's very important to draw a line to separate two categories, those at risk and those who have actually pre-symptomatic Alzheimer. Their risk is so high that we can name them Alzheimer's. So we have updates in our recommendations. So as I said, we stay apart from the Alzheimer Association guidelines that propose this biological shift to a pure biological concept of Alzheimer's disease, where you only need abnormal biomarkers to be labeled Alzheimer's disease. We keep with this clinical biological concept, so it's not only the biomarker, but also your risk. And as I said, we have new evidence for a high-risk group in sporadic Alzheimer individuals, especially those who have amyloid and tau positive biomarkers. And this is the main update that we propose in this 2024 recommendation. So in clinical practice, it's very simple. Only individuals who have symptoms should be labeled Alzheimer's disease. So that's completely aligned with the clinical biological disease concept. And for those who are asymptomatic, at the moment, there is no need of a screening, because there is no specific treatment or monitoring that is necessary for these individuals. But things will likely change in the upcoming years. That's why we foresee that these asymptomatic individuals will likely benefit from more investigation in the future, and we could then categorize them as having pre-symptomatic Alzheimer or being only asymptomatic at risk. And this will be crucial because, as you may know, brain health services that are led by Professor Giovanni Frisoni, who is the last author of this paper, are ongoing and will grow up. So there will be two clinical paths for individuals. Those who have memory complaint but no cognitive impairment, they will go to brain health services. They will have a tailored risk assessment, tailored risk communication, and tailored management. And on the other hand, you will have a classical memory clinic population, those with memory complaint who have memory impairment and who will be labeled as having Alzheimer's disease. So this framework, the International Working Group framework, is totally aligned with this, with the current clinical practice and with the future evolution of clinical practice that will involve the brain health services.